Yeah. Okay. Dear friends, good morning. Today we are going to discuss a very important approach for the accessing the very difficult lesions in the skull base. That is the anterior transpetrosal approach, which is popularly known as Kawase's approach. Who has devised this approach? And in his name, this approach is called Kawase's approach. The petroclival lesions are very difficult lesions, and there are various lesions in the skull base called petroclival meningiomas, chordomas, schwannoma. Sometimes they go to multiple fossa, middle fossa, posterior fossa, invertebral fossa. Then epidermoids can go to the in the whole of the skull base that can spread into the cistern, and there are then some other lesion in this location. So the problem of treating these lesions in this location, because they are very deeply located and very complex anatomy around to access these lesions. These tumors, when they grow large, they can produce a severe brainstem compression, and there are very important neurovascular structures, vascular nerves, brainstem. There are so many structures around, and the brain retraction, because these lesions are very deeply located. To go in the depth, you have to retract the brain to access these lesions. So there are various approaches to tackle these lesions, and the important approaches which I have shown here: lateral suboccipital, frontotemporal, then there are various posterior petrosal approaches, then the anterior petrosectomy approach. So what we are going to discuss here is the extended middle fossa approach for the petroclival lesions, which is popularly also called as the Kawase's approach. The Kawase's approach is a simple approach, and there is a very minimal invasion, and it is very less time consuming. Within no time you can reach to the lesion, and there are minimal complications by using this approach. You can get higher rate of tumor resection, and there is the advantage of this approach is it provides the direct view of the clival region, and with preservation of the temporal bridging vein, which is very important, and the cochlear organs. It provides excellent view from the mid-clivus to the cavernous sinus. This can be used for the extradural lesions as well as the intradural lesions. And you can clear the dural attachment under direct view, and there are less chance of injury to the lower cranial nerves, and also the retraction damage is minimal. Coming to the indication of using this approach is particularly the upper clival lesions and the prepontine lesions or tumors which are medial to the ISC. And these are the lesions which we have told earlier: petroclival meningiomas, trigeminal schwannomas, clival chordoma, prepontine epidermoids. This approach also can be used for the tumors which are attached medially to the trigeminal nerve, or the dumbbell tumors, which is tumor extending into the middle and the posterior fossa. Sometimes this approach can be used for the aneurysms. These are the basilar trunk aneurysms, which are located between the dorsum and the ISC. These are upper basilar trunk aneurysms, or aneurysms in relation to the ICA, or vertebral basilar junction aneurysms. This approach can be combined with the resection of the zygoma. Then it is called zygomatic transpetrosal approach, which is sometimes required when tumor is extending higher up, higher than the posterior clinoids. Then you need to have a lower access. By removing the zygoma, you can get a better access to access the lesions which are above the posterior clinoids. When the tumor is also present medial to the ISC and also extending lateral to the ISC, then this can be combined with the translab approach, and you can excise these tumors. This is the depiction by Professor Kawase. This is an schematic diagram. What is the meaning by anterior transpetrosal approach? And this is the darker area which is shown here is the tumor, which is medial to the seventh eighth nerve complex and medial to the trigeminal nerve. And the part of the tumor is under the Gesselian ganglion. And this dotted area is the petrous apex area, which is needs to be removed or drilled out to access this tumor and gives the direct access after the petrous apex is drilled. The surgical technique, the patient is positioned in the supine with head lateral, or can be not fully head lateral, but some kind of more rotation, not completely lateral position, so that the petrous area it remains in a shallow when you access, when you do a craniotomy. If it is in complete lateral position, the petrous apex area becomes the farthest from the dura. So if it is rotation in between, maybe about 45-degree, then the petrous is in a kind of some kind of reclining position, and the petrous apex area is little shallower. So once this bone flap is removed, in this picture, you can see the temporal fascia flap is taken separately and the temporal muscle is reflected anteriorly. So there is nothing in between the approach and the temporal muscle. So once this is the bone flap is removed, you can reflect the dura. Extradurally, you can access the middle fossa. So in this picture, you can see here, this is the petrous bone, and this is the middle meningeal artery, which is already coagulated and cut. And this is the middle fossa dura, which is reflected medially, and we access the tumor extradurally, and we release here this dura from the GSPN. Once this dura is reflected, and you can see this area, this dotted area is the petrous apex area, and the various structures in the surrounding is, this is middle meningeal artery, which already has been coagulated and cut. The ICA runs like this in this horizontal segment of the petrous ICA, and these are the structures of the middle ear and the cochlea. So we are medial to the arcuate eminence, and this is the area which needs to be drilled to access the posterior fossa to remove these tumors. So once this petrous apex is drilled, you can see the tumor is in the axis. Tumor is seen in the area. Now the next step is to ligate the superior petrosal sinus. So it can be ligated with the clip, or it can be ligated with the suture. And you have to cut in between these two. And from there, you can cut the tentorium up to the tentorial edge, so that it becomes the single cavity, middle fossa and the posterior fossa. And this is the next picture, which is seen here. The tentorium is reflected after cutting up to the tentorial edge, and the various structures in the middle fossa and the posterior fossa, right from the third nerve up to the seventh eighth nerve complex, you can see here. And this is the tentorium, which is reflected, and this is the petrosal vein, which is very well preserved in this approach. So here it is. Once this tentorium is reflected, you can see this is the metal cave area, and this is the basilar artery, you can see, and this is the tumor which is medial to the fifth nerve. And you can mobilize this Gesserian ganglion. And here in this next picture, you can see the tentorial feeders, which is directly supplying the tumor. And this is in direct vision, you can devascularize this tumor by coagulating the tentorial feeders, and the tumor can become avascular, and then it becomes very easy to decompress this tumor, and this tumor can be removed completely. Once the tumor is removed, it needs good repair. So this middle fossa dura and this temporal fascia can be stitched, and over that the temporalis muscle can come. And sometimes you need to put the fat graft in this tumor cavity so that not to have the CSF leak. So this is the brief idea about the basic approach, what the Kawase approach mean. So when you do in the cadaver dissection, once this middle fossa dura is reflected, you can see the various structures. The first and foremost thing you see is the tegment tympani. Then this elevated area, this is elevation, is arcuate eminence, and our area of interest is medial to the arcuate eminence. So this is a quadrilateral area, or the Kawase's triangle, or quadrilateral, which is laterally bounded by the arcuate eminence, posteriorly by the petrous ridge, medially by this V3 division, and anteriorly by the GSPN. This is the small area which is devoid of any important structure. So once you drill this, you can access the posterior fossa and the tumor which are present in the middle fossa and the posterior fossa. You can remove these tumors without much problem. So this is further drill the petrous apex, and you can see this is Gasserian ganglion, and this is the greater superficial petrosal nerve, which runs anteromedially under the third this V3 division, and this connects to the facial nerve. This is geniculate ganglion here. This is semicircular canal, and this is foramen oval, which is V3, which is going there, and this is middle meningeal artery. Once this petrous apex is drilled, and you can see the whole area of the pons here. So this is the basic approach to remove these tumors in this location. This is another picture which is showing all the structures in the after the complete exposure of this Kawase rhomboid has been done. This is trigeminal roots, which is arising from the pons, this trigeminal ganglion, and these are the divisions V1, V2, V3. IC is here, middle meningeal artery, greater superficial petrosal nerve, and this is superior petrosal sinus vein. So these are the important structures which you see in the view once you have that complete exposure in this area. So this is these are some of the examples which I will show you, which I have used. I exercised this approach removing these tumors. Earlier we used to use the posterior petrosectomy approach for removing these tumors, but once I had visited Professor Kawase's place and I have learned this technique. From then onwards, I have used this approach for this kind of tumors. So this is tumor which is done, I think, operated very long back in 2002. And this you can see here, this was the direct approach from here. This is just temporal fossa craniotomy and this petrous apex removal and complete excisional tumor using this approach. This is another tumor, large petroclival meningioma, which could be excised by the same approach. And this is post-operative CT scan shows complete. This also I operated almost in 2008-9, long back. These are some more examples. This was operated in Medanta, Gurgaon when I was in 2014 there. Almost 10 years ago, this tumor was removed, and this is post-op MRI, shows complete excisional tumor, and this is the fat graft usually we put in this tumor bed just to avoid the CSF leak. Another tumor, petroclival meningioma, and this is the different tumor. This is petroclival, this epidermoid in this location, which has caused already the amputation of the petrous apex. So here there is not much drilling of the petrous bone. You can, once you remove the temporal craniotomy, and extradurally you access this tumor, you are directly enter into the tumor. And this is the postoperative CT scan. This is another case of petroclival meningioma, but here there was a difficult problem. You can see here there is a brainstem pile breaching. There is a signal intensity change in the brainstem. In these tumors, what we do is we leave some part of the tumor here. This is a postoperative CT scan. This is a fat graft here. And this is the part of the tumor which we left behind, because otherwise it is going to cause a lot of deficits. And this remained stable. Subsequently, patient was subjected to the gamma knife and lesion remained stable. I have follow-up of 5-6 years, and this different stages we have done MRI, but lesion has not grown. So this is controlled with the gamma knife. So in all, the Kawase's approach is a very advantageous approach because it gives a direct access to allow these tumors to remove these tumors completely. Tumors particularly which are attached to the clivus, and it through a small area in the petrous apex you can access these tumors. Bloodless tumor removal can be achieved by detachment of the, this is very important. Tentorial artery is in a direct view. This is the biggest advantage because many of the meningiomas which are extremely vascular because of the tentorial feeders, but here in this case you can control the tentorial feeders in the very beginning before you start decompressing the tumor. You can make the tumor devascularize and you can then excise the tumor completely. It provides a direct access to the space anterior to the ISE so that it can minimize the injury to the lower cranial nerves. Also, as we have discussed earlier, there is a low risk of venous complication because you are not going to expose the sigmoid sinus here or vein of Labe as you do in the pre-sigmoid approach or the retrolab approach or a complete petroscopy. So there are venous complications are minimized by using this approach. So in short, I think I have explained brief about the Kawase's approach. Thank you very much.